This is Dr. Rottnek. He is the Director of Community Medicine at St. Louis University School of Medicine, as well as the Medical Director of the Physician Assistant program there. And he also went to medical school at this university. He is very passionate about providing healthcare for patients who are in the prison system, as well as homeless patients. And I think is a really interesting focus on addiction medicine. He's actually spent 15 and a half years as the lead physician at the St. Louis County Jail. And one thing I found really cool was that his personal struggles with mental illness really inspires his work. And it's really interesting to hear about how there are a lot of he's been working on these projects related to barriers to addiction treatment as well as recovery. And today he will be discussing healthcare in the prison population, and hopefully we'll also be able to hear more about addiction medicine. So without further ado, here is Dr. Rottnek.
Okay, thank you so much. This is the second year that I'm doing this talk with all of you, and which is a lot of fun because my favorite kind of medical students are the med students who like to get involved in issues of public health and health justice, and that's what motivates me. So as mentioned, I'm Director of Community Medicine here, but I'm also Program Director of our Addiction Medicine Fellowship. Addiction Medicine got approved in 2016 as a specialty with the same standing as ENT and cardiology and everything else. So we're just today actually starting our 6th year of our addiction medicine program here at St. Louis University. There are now 105 approved programs in addiction medicine. And when we started all this in 2019, there were 44 that were not approved, but they were just up and running anyway. So we are a growing field. And in addiction medicine, one of the cool things about it is that we have people coming in who have completed their residency, and in addiction medicine, it can be any approved residency, either ACGME, and I know there's the DO equivalent just fled my head, but I know there's a version of the accreditation body for the osteopathic medicine. And so we've had in our program, we've had family docs, internal medicine, OBGYNs, emergency medicine, a pediatrician. So it's pretty cool building the workforce in this area. But one of the other hats I wear is correctional healthcare. So for 15 plus years, I was a medical director at the St. Louis County Jail and Juvenile Detention and the lead doc, which basically gave me the confidence to be able to start an addiction medicine fellowship because I'd been doing it already. And then I wasn't out long. It left the fall of 2016 when I started as medical director for St. Louis City Juvenile Detention, because our city isn't part of the county. We're one of those strange places in the US where the city got booted out of the county 100 years ago. So I've never been far away from this topic. I love talking about the intersection of how we can provide prevention, harm reduction, and treatment services to people in the criminal legal system. In fact, I'm working with SAMHSA right now, the Substance Abuse and Mental Health Service Administration, on how to improve services for people with opioid use disorder who are in prison and also in the reentry process. So we'll talk about that today too. I am not a formal guy, so if you've got a question with what we're talking about today, feel free to unmute and holler, or feel free also to just put a question in the chat. If you want to do that, that's cool too. And I'll leave time at the end so we have time to talk about questions as well. Because what my goal is today is just kind of give you an overview of how the criminal legal system works, but then also opportunities to intervene, including things that you can all do as medical students and grad students and undergraduate students to improve the care of people in your state. And I just learned this 2 weeks ago. You guys have an incredible prison program in Maine. And I don't know if any of you know that, but you need to look it up, because until we can get rid of the industrial prison complex that we have in the US, we've got to provide the best possible support for people who are incarcerated. And that includes learning new skills and new education, providing treatment for substance use problems and mental illness so that people don't end up in the criminal legal system. I was at a working group in DC a couple weeks ago, and the commissioner of prisons in Maine was one of the main speakers. And he is a rock star. He knows more about addiction treatment than most physicians do in the US. So it was inspiring to meet somebody who's really trying to do the right things. Okay. All of that by means of introduction. Now we can jump right in. Okay. What we'll talk about today, basic elements and structure of the US criminal justice system. We're going to talk about how a person interacts with the systems and opportunities for interventions to break the typical cycle of incarceration. Um, we'll talk about mandates for healthcare in US jails and prisons. We'll talk about some aspirational versus real world practices of working with folks with substance use disorder in these settings, what really goes on behind bars, and then we'll finish up with some opportunities for advocacy in this work. Okay. Why should you care about correctional health care? Well, you guys are great. You're doing this program because you care about these things. But what I tell people who don't necessarily care about folks behind bars is most people behind bars shouldn't be there. We have a broken system in the US where particularly minoritized populations are much more likely to end up in the criminal legal system than people who look like the majority of us on this call. Um, Poor people in particular have worse outcomes because they can't get attorneys. Public defenders are understaffed and all those things. Also, incarceration in the US is basically wasted time in most systems. We don't even talk about rehabilitation in most prisons in the US. A lot of prisons in the US are run by for-profit companies that are just worried about paying their investors. They're not there to help people stay out of the system. In states like Missouri, and I'm a St. Louis native, so I can badmouth Missouri. I tell my med students here at St. Louis, you don't get to do that until you've been here for at least 4 years. But in Missouri, most of the good programming done in our prisons are done by volunteers. It's not done by the state and paid for by the state. Why else should you care about correctional health care? Most people in prison come back home. 10 to 15% of people will die in a prison because of their sentencing, but most people come back home. We don't want people coming home sicker than when they entered. And then also, and the graphic here is to support this, when somebody's incarcerated, it is ripples in the pond. You incarcerate a parent, particularly a mother, the kids suffer because of that. The family suffers, the community suffers. You're taking people out of the workforce, especially if they're there unnecessarily. And there's lots of ways that we can monitor people's behavior other than just locking them up. During the first year and a half of COVID, I was doing a lot of jail inspections around the country because people were being held in jails on $500, $5,000 cash bond, despite the fact that they were at high risk for getting COVID. So here, stupid Fred was going to Detroit and East Baton Rouge and Atlanta and doing jail inspections of people who were really high risk of contracting COVID at the time where there were no guidelines yet from the CDC on what to do in detention centers. but it really reinforced to me that it wasn't the people who were incarcerated bringing in the virus. It was the staff, it was the attorneys who would pop in, work their shift, and then go back home to the community. So jails and prisons became incubators for the COVID virus. So I'll try to stay on tack. So here we go. So let's first talk about how the US criminal justice system is set up. Because most of us, unless we've had a loved one behind bars, these are folks who are usually out of sight and out of mind. So we'll talk a little bit about terminology, about jails and prisons for the first part. Jails are located near the courthouse. When somebody gets arrested, they usually go to the jail to find out what their charges are. Every county in the US has to either have a jail or work with another county who has a jail. Think like out west where there's very low population counties, they might share a jail. Most people in jail are pre-trial, waiting to find out to appear before the judge, or they're there for short sentences. Rapid turnover of population. The vast majority of people in a jail setting will go back home. They don't go on to prison. They might be there waiting to find out what the fine is, or if they need to do some time as punishment based on their charges. A lot of frequent flyers, a lot of people who show up frequently. Think of people who have trespassing charges, poor people who might get picked up for that. Supreme Court ruling that was released last week that states it's okay to make sleeping on public land illegal. That's going to cause a lot of changes now with people who are housing insecure. Think of people on minor charges. Riding public transportation and you didn't buy a ticket. It's not a real good use of our taxpayer time to put people behind bars for a week for that. And the health status of folks, often unknown, untreated, uncontrolled health problems. Until 2 years ago, Missouri was still one of the, I think there's now still 12 states who don't have Medicaid expansion. So young men, by and large, if you're poor, didn't have Medicaid, didn't have insurance coverage. So people might have had a diagnosis or not even a diagnosis, but didn't have access to a healthcare provider. So people show up at a jail. They didn't know they had hypertension, diabetes, an STI, et cetera. And that was that real risk for them. And also people at jails coming right in off the street, highest suicide risk of any population in the US. Because if you think about it, somebody just got arrested. They may or may not have committed a crime. And if they did commit a crime, most violent crimes in the US are domestic, which means that the violence occurred between people who knew each other. One of the people who's usually the person initiated the crime might have been drunk, might have been high, might have been untreated or undertreated mental illness. And these are all things that once people get treatment and or sober up, they realize what they did. And treating grief is something that's a very real thing in a jail setting when people sober up and realize they committed a crime against a loved one because they might have been under the influence of alcohol or drugs. Also, you're taking somebody and putting them in an environment where they have a brand new roommate they didn't ask for, the brand new clothes. They're in a loud situation where the lights are on, where they're no longer in control of their own sense of self. So it's a very high suicide risk that what happens behind bars. Now, prisons. Prisons are where people go when they've been convicted of a crime, either from a judge or a trial, or they agreed to a plea bargain. That's why the term convict is typically used with people in prison. They've been convicted of something. Nobody shows up at prison as a surprise. They've either been through a jail and through a process, and then they show up in prison. And I've got a great graphic we'll talk about here in a little bit. Usually there's more freedoms in a prison setting, more routines, less supervision. If you've watched movies like The Green Mile, The Shawshank Redemption, things like that, where you see these big buff guys working out in the weight room or running laps outside, that's probably a prison because there's a lot more freedom, but a lot less supervision, which means prisons are more likely to have folks that have violence, rapes, etc., in a prison setting. Somebody has usually been evaluated by somebody at a jail before they come to a prison. So usually they'll have a diagnosis or medications coming with them. I'll tell my students, you want job security, go into geriatrics and work in a prison because there's a significant number of people who will die in prison because of their age and because of their sentencing. There's two versions of prisons. There's state prison systems. Every state has a prison system, but there's also a federal prison system. And that depends entirely on what charges somebody has. If somebody's in a state system, those are usually people that have committed a crime within a single state. Federal prisons are people have had a charge related to something federal. Think post office, think banking, think drugs, because a lot of the drug trade crosses state lines. If something crosses state lines, the charges end up being in a federal system. Okay. Again, there'll probably be more questions and answers for some of you today, but I've got good resources in the end if you want to learn more about this. Now, let's talk about the impact of the number of people in prison in the United States. Okay. These numbers are from 2022, which is pretty impressive because if you've done public health, you know it takes a few years for data to trickle down into the public. This gives you an idea of how many people are locked up, how many people are behind bars in the US. And in 2022, and it's about the same now, 1.9 million people. So that's a lot. That's 573 per 100,000. This pie gives you an idea of where people are locked up. Jails and prisons, we've been talking about, local jails and state prisons, and then federal prisons and jails. Again, this has to do with sometimes the nature of charges, with usually drug-related work. But during COVID, I did an inspection of 2 jails in rural Maryland that held folks who were detained by immigrations and customs. So they were ICE detainees. So that fits into this group here. And this little wedge here is blown up here where young people behind bars, territorial prisons, immigration detention, and then folks who are considered not competent to stand trial. That's something that my last meeting was with folks in Missouri because at my treatment site that I contract out 30% of my time, they want us to do medication management for folks with psychiatric disorders being held until they are considered competent to stand trial. So there's all kinds of reasons people are behind bars, but the number is almost 2 million people every year. So it's a lot of folks. Now, let's go back here for a minute. We're taking this pie chart now, and this is going to be a wedge for our next slide. All the people behind bars from the last page, now add to them people on probation and people on parole. Now, what's the difference? Probation is where we try to keep people out of jails, prisons, and detention centers through what we call community corrections, where we tell people, hey, if you're headed, you've been convicted of something, but rather than sending you off to prison, let's keep you at home or in the community. Maybe you've got an ankle bracelet. Maybe you've got a probation officer that you check in with. Maybe you are going to a treatment court. where rather than locking you up, we're going to provide treatment resources for you to get treatment for mental health and or substance use, or there's all kinds of treatment courts now. You're a veteran, so maybe you have a few different areas, but these are the goal of these probation programs are to keep people out of jails and prisons, because what you want to do is minimize time for anybody in a jail prison, because you learn new skills when you're in jail and prison that are not necessarily pro-social. Okay, people always learn new things, so the less time you spend in jails and prisons, the better everybody is. Now, what parole is, the gray wedge here, that is for people who maybe completed a minimum amount of time behind bars, but and they get released, but they have to have a certain period of time that they check with a parole officer. Again, it might be check-ins, it may be treatment options, but it's a bunch of rules that somebody has to follow until they fulfill the requirement of their sentence. Many states lump probation and parole together, and it's called community corrections. But the goal of both of these is to minimize time spent behind bars for any individual, because too often that time is not productive, it's high risk, and it's keeping people away from families, away from supportive folks, away from working. So if you look at this now, the number went up from about 2 million to close to 6 million people are under supervision of somebody in the criminal legal system. Now we're going to take a look at the next slide that'll really blow you away. Here's the 2.3 million or so incarcerated today. About 5 million people in the US were formerly incarcerated in a program. Now, if you look at people who have ever been convicted of a felony, the number bumps up to about 20 million. This becomes really important because there are certain occupations that you cannot participate in if you have a felony on your record. For example, medicine. You cannot practice medicine. You cannot get a license in most states. You cannot get DEA registration, get on insurance, etc., if you have a felony conviction. Same with nursing, same with many behavioral health professions. It also affects where you can live and what kind of state or federal jobs you can apply for. Now, if you look at the number of people in the US that have a criminal record, out of about 300 million people in the US, about a fourth of them have a criminal record. Now, again, you might think, well, that's a shame. They shouldn't have done a crime. Okay. Not everybody who gets convicted, people who plea bargain don't always have committed the crime, but that criminal record can affect job prospects, where you can live, etc. And then the one that really blows me away, over a third of people in the US, a third of the folks have an immediate family member who have ever been to prison or jail. So that's where you see the ripples on the pond really affect communities. Has anybody on the call here ever been to St. Louis? Okay, no. All right. Oh, we got one person. Okay. The Mississippi River is here, more or less. Illinois is over here. Missouri's over here. Highway 70, which is one of our major highways, is here. Now, if St. Louis U, think of it kind of as right here at where my two palms come together. And that's where the Gateway Arch is. Okay. If you come to St. Louis and you drive north from St. Louis U about 2 miles and you get into this wedge, you see where neighborhoods have just been devastated. And it's not just because of crime, it's because so many of the people who live in that wedge-shaped area have been disproportionately impacted by incarceration, where we have taken a generation of people out of the workforce and locked them up. And because of that, we're tearing down brick buildings. They're empty lots now. And you just go, what is all this vacant space doing in St. Louis? So we're trying to figure out what part of criminal justice reform is getting people back into the workforce and rebuilding neighborhoods. Okay. So now we kind of gave a big picture of what are jails and prisons, what's the impact broadly in terms of numbers. Now we're going to talk a little bit about how somebody moves through the system. All right. This is the graphic that I use whenever I talk about correctional health care and working with folks behind bars, because I think it is a really nice tool to kind of get a handle on how people move through the system. This is put together by SAMHSA and the Gain Center, and I'm working with them right now on increasing OUD treatment, opioid use disorder treatment, to folks in Wisconsin. But 6 intercepts. It starts with intercept 0 because after they rolled out the first intercept model 20 years ago, they realized they missed something, so they started a 0. Intercept 0 is where people are not interacting at all with law enforcement, which is ideal. If people are having crises, mental health or substance use crises, the goal is not to have them involved in the criminal legal system. And those are crisis lines. 988, right? Have you all heard of that? 988. Every state now has a 988, which is a 911, but geared towards people having a mental health crisis and getting resources to folks, ideally, so that they can mitigate that crisis. And if they need treatment, great, get them into treatment. If they need resources, get them resources they need. The goal is to decrease suicides, but the way we want to do that is by helping folks in mental health and or substance crises. Intercept 1 is law enforcement. That's where 911 comes in and local law enforcement comes in, but this is also where you might have crisis intervention teams. Has anybody heard of a crisis intervention team on this call? That's where you might have behavioral health clinicians or social workers riding alongside police, so that if they get a call that there's an emergency and it sounds like a mental health or substance use crisis, rather than the assuming safety gets scoped out and all that, rather than somebody ending up in a jail, perhaps a behavioral health specialist can de-escalate the situation by working with the person that got called on with the 911, and somebody can get in emergency treatment or into services rather than ending up in jail. It's a model that is rolling out in different parts of the country. And again, the goal is, unless somebody absolutely has to be detained behind bars, what other options are there? And that's not just the emergency room. In fact, the last place anybody wants to be with a mental health crisis is an emergency room, except a jail. Okay, we'll say the second last place is the emergency room, because there's nothing therapeutic about an ER, right? If you've been in one, you know the goal is to get somebody out of the ER. So if there's other options, treatment options, sobering centers, other places where people can go in crises, that's a better option to go. But if somebody does get arrested, they end up at Intercept 2. That can be a jail, that can be a detention center, and that's where they'll show up and they'll appear before a judge usually, and that judge will either have them remanded to jail, or they can bond out and wait to go to trial, or they may go to a specialty court. And specialty court, again, depends on the resources of the county that you're in. In St. Louis County, we have a drug court. We have a court for folks with driving while intoxicated. We have a veterans court, and we have a family court. Whereas if there's legal issues related to any of those 4 buckets, the judge has the discretion of having somebody go to a specialty court. What that means is usually the person is able to either go home or stay with a family member rather than going to jail or prison. There's a lot of requirements there and they don't always work well, but it's an option. If somebody goes to jail, then they usually end up going to prison, which isn't part of this model for some reason. And then after they serve time in prison, they come back out through a reentry process, through parole. If somebody comes out of jail without going to prison, they have a reentry process and they may end up going on probation. Now, the reason that I use this is because it kind of helps unpack a little bit of these different stages, but it also gives agencies, people, community health agencies, federally qualified health centers, other groups who want to kind of help break the cycle, realize I can do something at Intercept Zero, or our agency can do something with law enforcement. Maybe we can do something providing services in a jail setting, reentry programs, or with probation and parole. So the reason SAMHSA really worked on this model was not to help communities map out who's doing what in these settings in the therapeutic side of things so that we can pull people out of the criminal legal system or cut down recidivism where people end up back in the system. Does that kind of make sense? It's kind of just a way to kind of break down what's a really complicated system to see how can we support things. If any of you done any work with agencies that do harm reduction with naloxone distribution or syringe access, okay. I always tell folks who are doing that work, a great place is to work with crisis teams to find out how to provide naloxone maybe to people who are still using, who aren't ready for treatment. Another great place is to work with reentry programs and probation and parole. That's a place to get people into treatment, but it's also a place to get people naloxone, because one of the risks we know people have is if you've come out of jail or prison and you have a history of an opioid use disorder, you're at high risk for overdose in the first 30 days that you come out of prison or jail, because your body hasn't been using for a while. And if you're tempted to use again, you want to make sure there's people in your life who can help reverse an opioid overdose, because that's a high risk time. Okay. We'll come back to this model at later points so far today. Anybody got any questions so far? Okay. I'll assume that these bright-eyed people on the call here, it's all making sense. Okay, good. I love the fact that I don't have to nag anybody to put on their camera. You make me happy. Okay. Okay, we'll talk a little bit about diversion stuff, but we're not going to focus on that for you today. All right. Let's talk about healthcare services behind bars. One of my happy places here at St. Louis U is I have a secondary appointment in our School of Law, because we have one of the best health law programs in the country. All the people, all the faculty and students in the health law concentration are people who look at issues of access to health, Medicaid and Medicare coverages, um, disability law, um, insurance law. And you might think, oh my God, that sounds so boring. But it really impacts the patients that we care for in medicine. It's like, how do people get in to see us? How do people's bills get paid for? Who has access to care? In my world, it's really important because the Eighth Amendment to the Constitution, which is my tattoo on this arm, is the first bullet point here. Excessive bail shall not be required, nor excessive fines imposed, nor cruel and unusual punishments inflicted. Now, the reason this is important in the corrections world is since 1976, the Supreme Court has ruled that this Eighth Amendment guarantees people in jail, prisons, or detention centers to have a right to health care. Now, if that seems really crazy to you, it should seem really crazy to you. It's the only part of the population in the US guaranteed a right to health care. But it's guaranteed based on the ruling of the Supreme Court. So not to get too political, but I'm not getting paid anything, so I can get political. With our current Supreme Court, I would not bring this up to them because who knows if they'd reverse it or not. But the point is, if you're behind bars, you're guaranteed a right to health care. Now you might be saying to me, Dr. Fred, I have heard some horrendous things about how people have been neglected behind bars in jails and prisons. And I will say, absolutely. And you'll say, but why? You have this Eighth Amendment. And the reason why is that jails and prisons are not considered healthcare facilities, which means they don't have to meet any accreditation standards, which means legally, a jail or prison gets sued. Okay, great question. And yes, we'll get to that. Jails or prisons get sued because somebody didn't get medical treatment. All the administrators have to say is, we did our best based on our resources we had. If you think that's really pathetic, it is. Okay. And that's why I will work with civil rights firms that are suing jails and prisons to say somebody died wrongful death because they did not do the minimum, which is at least ask them about their health care concerns. So that's why we ask, is this the ceiling or the floor? I think it's the floor. I think if you can not provide the health care needs a person has, you have no right to incarcerate them. If they need to be incarcerated, put them in another jail that has the resources to do it. And that means people get incarcerated who have type 2 diabetes and they don't have blood sugar monitors at a jail. That patient shouldn't be there because you can't provide the basics. You've taken away their autonomy and you are now in charge of their health. And that might sound harsh, but these are the things that I talk to people about all the time. Somebody asks in the chat, I've seen dramatizations in the media where a character commits a crime to receive health care. Does this really happen? Absolutely. Before Medicaid got expanded in Missouri, in my home, my correctional home in the county jail, St. Louis County is not rural. It's a bunch of municipalities, so it's very suburban. And we were in one of the highest, the county jail, the main jail was in a very high per capita municipality in St. Louis County. There was a newsstand right down the road, a block away from the jail, that every winter somebody would throw a brick through the plate glass window to get arrested in order to get a place to sleep and 3 bologna sandwiches a day. So that is for real. I've taken care of people who had cancer, who couldn't afford treatment. So they took a gun into a bank. So it happens. Okay. Medicaid expansion states, but it still happens. Okay. All right. Now let's take a look at what happens when somebody comes into a jail setting. And we're going to focus a little bit more on addiction stuff because I've adapted the talk we do here. You can see at the bottom, the American College of Academic Addiction Medicine. I do a talk every year for all the addiction medicine fellows in the US on basically what we're talking about today, the intersection of folks with substance use and folks who are incarcerated. So, initial incarceration, and again, I'm going to focus on the jail stuff. One, because I know that better, but two, because by the time people get to prison, they've at least been screened by somebody. Okay. So, and during somebody's initial incarceration, they get picked up by the police. and they get screened for their health conditions. Now, in medium-sized and large cities, they will probably have at least a nurse or an EMS person there at least through business hours. Now, very small towns, very small counties, very rural counties, they may have a nurse come in 1 or 2 half days a week. And the sheriff or the people running the jail will ask the health screening questionnaire. Now, think if you were just arrested, especially in a small town, and everybody knows you in your business, you may not be really open to being honest about a mental health issue, a substance use issue, having HIV, having Hep C, you name it, right? Because people might already know you, or you just don't trust people. There's a lot of populations in the US that fear the police for very good reason because we have set up systems where they should fear the police. So you might not be very honest. So everybody should at least ask questions about health conditions. A lot of people will get a drug screen, but you get what you pay for when it comes to a drug screen. If you probably everybody, most people here have peed in a cup to go to medical school. Um, that that urine drug screen may or may not have screened for fentanyl, and that's the main thing killing people today. It may or may not have screened for methadone. It may or may not have screened for Vicodin, um, hydrocodone, oxycodone, etc. So you get what you pay for. Every jail should have naloxone present because people will smuggle contraband into jails. And I'm not just talking about people who are arrested, I'm talking about guards and prison officers. So everybody should have that in there. And we've already talked a little bit about people who are just been arrested and in a jail, highest risk of suicide of anyone in the US. Again, ideally, these screens should be made by licensed medical staff. St. Louis County, we've got nurses present 24/7, 7 days a week. But we're also a mega jail where we have 1,250 beds. Again, it depends on where you are. If somebody's on medications and they tell us they are, who's your providing provider, or your prescribing provider? Where do you get your meds? We call the county and most jails will know to call the pharmacy before they call a doctor's office because pharmacies tend to be open more. And depending on the jail, if they can confirm your meds, we can continue you on them. Again, at St. Louis County, we have a pharmacy. We have stock meds because we're a busy jail. Smaller jails won't even have stock meds, so they might have to wait to get the meds delivered from the pharmacy. Somebody might have to go out and get them, etc. Initiation of meds for substance use disorder, again, highly variable in what's available. Even though opioids suck all the air out of the room now in 2024, many more people die from alcohol overdose and alcohol detox every year than people dying from opioids. Alcohol detox is what we worry about. It's not alcohol intoxication when they come into a jail, it's coming off of alcohol. Opioids, it's rare for jails to do opioid treatment still. More prisons are starting to do it. The thing with opioids is that you don't die from withdrawal, but you feel like you're going to die. And a lot of people have committed suicide coming off of opioids and feeling like they're never going to get any relief from the symptoms. Benzodiazepines, things like Ativan, Xanax, Librium, second most toxic detox from alcohol. What we did at the St. Louis County Jail when I started there in 2001, 23 years ago now, first thing I did as a family doc was we got to get people as comfortable as they can be. We got to keep people alive and we have to provide the safest possible detox for them if they're going to be here for any length of time. So I started comfort meds, things like a blood pressure medicine to make sure that when people came off of meds, they weren't getting rebound hypertension. In other words, their blood pressure would bump right up. And also I'd start them on a blood pressure agent that helped with some of the jitters that people had when they come off the meds. We got on something for diarrhea, something for vomiting, and something to help people sleep for 7 days. To this, and it took SAMHSA about 15 years to catch up with that, to say, hey, maybe we should recommend this for everybody in jails. And the reason I did it was not only because it was the right thing to do in terms of compassion, but when people feel better, they jail better. And I know it's funny using that word as a verb, but people do better behind bars if they feel better. So help them feel better, help them sleep, help them feel less anxious, encourage them to drink water as frequently as they can so they stay hydrated. So now I still do talks to big jails and say, hey, everybody wins. Officers in the jail, the health staff, everybody wins with comfort meds. So even if you're not at the point of getting people on SUD treatment, at least help them be more comfortable when they detox. Okay. Reality, as you can imagine, and we've talked about a lot of jails don't have the staff to do this work. Jails are funded by the county in which they're located. So the bottom line is, you've got a poor county, they're not going to have good staffing for anything, anyone in the criminal legal system, much less who's ever staffing the jail, much less who's ever providing health care at the jail. Innovation in this work often comes from mid-sized to large cities because they have a tax base to provide the healthcare services in a jail or in a detention facility. Now, I am not advocating to build bigger jails or to get more tanks for the police, but I am advocating for get adequate health care for people who are behind bars. Because if you don't, sick people get sicker, people end up dying, or people end up going back to the community with worse health problems than they had when they came in. So that's usually my approach. So that's where you look at the same kind of situations we talked about before, the ideal versus the real. Who's doing the screening? Calling pharmacies. Most jail staff do not have time to get people fed and get people to the showers, much less calling a pharmacy. Alcohol, people will send somebody out from a jail if they're worried about detoxing, because jail staff know now that people will die from alcohol detox. But usually with opioids, it's a forced detox. Benzos, again, too much time and energy. And comfort meds, people still look at me and say, comfort meds? Why would you give somebody comfort meds who's in a jail? Those are the same people who will say to me, why would you give people naloxone when they're getting released? Aren't you just enabling them to go back and use opioids? It's like, no, you're helping people stay alive until they're ready to go into treatment. So lots of opportunities for improvement there. We've been talking again about, I never follow my slides, so, but you'll get these slides too, so you'll be able to look at resources and stuff with this. We've talked about alcohol. What do I tell people? If you have an infirmary in your jail, if your jail's big enough, you want to give people a couple bags of IV fluids to get them hydrated. You want to get them on benzos and comfort meds to help them detox. You guys are still early in your medical career. You'll learn this stuff. You'll be taking care of people in the ICU at hospitals. But the point is that you can screen people and you can provide treatment even in not well resourced conditions. I cut my treatment chops by working in homeless shelters for 6 years before I started working in jails. And that was when I was a med student and a resident. And then when I was faculty for a couple of years in our residency program, I would take down samples from our sample closet to our neighborhood shelter downtown St. Louis run by the Salvation Army. And they did what was called a dry detox, which meant no meds, nothing special. And people died there. And they would come to us on Tuesday night at Harbor Light. And I would tell these guys who had a significant alcohol habit, I would give them a sample bottle of meds that was good for a week. And I would say, tell your program director that the doc said you've got blood pressure problems and you need to take this. So they would take something for blood pressure just to help them not stroke out from alcohol detox. Unfortunately, I had to do CPR a few times down there where guys died who were in the program, and they called me when we had clinic. But the point is that what taught me is that when people have access to even minimal care, they get better. And it's a chance in a jail setting to treat people humanely. They're more likely to come back for care in the future, not just in a jail, but in the community. Whoa. Listen to me being a audio recording. These are different screens. I won't go through too much, but they are screens for alcohol use. You can take a look at those. And every substance use disorder, again, the challenge here that I've probably been beating you over the head with, you've seen one jail, you've seen one jail. They're all different. Little jails have a real challenge, again, just to get food to the folks there, get them to the shower. Large jails have more flexibility, but everybody should be trying to do something when it comes to treating folks with substance use disorder. Let me skip a few slides here. Let's come back to this slide, because with this slide, we're going to focus a little bit on public health opportunities for things that all of you are talking about with the program you're doing this summer. So what are some opportunities to look at policy pieces, to work with folks from a more 30,000-foot view? You'll get the clinical stuff soon enough, okay? But while you're still young and thinking big, let's talk about the stuff where you can think about how can we make better systems of care, and how can I partner with people other than physicians to do some of these bigger systems of care. I've already talked about cool things we can do and that we do in the law school, but also working with social workers, working with your own local and state government officials, your reps, your senators, working with government agencies is all really important. And one thing that I really want to impress upon all of you on the call today is if you have the opportunity to work with people who run your city or run your county or even your state rep or senator, they love hearing up from medical professionals. And med students, you are a medical professional already. Think of that big tuition that you pay makes you a medical professional. Okay. Your reps and senators love hearing from you. If there's a topic going on at home or in Maine or wherever you are, having your rep on speed dial is a cool thing. I've had my local rep, who's now our local senator, she's called me on policy things and said, Fred, what is this? What do I want to do here? Because we expect our reps and senators to know all this stuff. No, they didn't go to medical school and law school and real estate academy and foreign law and everything else. So when they have somebody they can call, it's a cool thing. That's why it's great that you guys are interested in this. Okay. Let's go back now. We're going to walk through this intercept model. And remember, intercept 0 is community services. How do we keep people out of jail, out of prisons, out of detention centers? Well, guess what? Expanding Medicaid is a good policy. Maine has expanded Medicaid. Helping people figure out how to apply for Medicaid and how to, if they make too much money for Medicaid, how to apply for Marketplace, right? The ACA programs. Most people are on Medicaid in the US, remember, they're working full time. They're working for places like Walmart and Costco and Sam's, where, or CVS or fast food. They're making more, they either can't get enough hours, so they're Medicaid eligible, or they make too much to make Medicaid, and then they don't know how to get ACA, because less and less employers have employer-based insurance. That's what I grew up with. So helping people access services is really important. Helping people know where to get treatment for substance use disorders. You can go to your state DMH, Department of Mental Health, and usually get a good list right there, or a hotline on where people can go for treatment. Same with mental health. Combining in-person and telehealth services. We learned a lot during COVID that we can do some super cool stuff with virtual healthcare. One of the areas we benefited from is telehealth and getting treatment to people for substance use in rural areas, in places where people were sheltering in place with their family, places that couldn't get to treatment providers unless they drove a couple hours. We don't want all that to slap back. So the feds are working on, they've delayed stuff, and they're supposed to come out with something in December on a final rule on this. Not everything is ideal. Nothing's ideal by telehealth. It's really ideal getting people in person. But if we can do a mixed modality where maybe we see somebody in person every 6 months and check-in visits can be virtual, that's great. You know, let's think differently. And then implementing urgent care programs and sobering centers. Have any of you heard of a sobering center before? That's where we can get somebody into care. Again, it tends to be bigger cities. Let's say somebody's been picked up in the community by the police or by first responders because they're acting out in public and they're probably drunk. Last place they need to go is the emergency room. Instead, maybe we can get them to a sobering center where they're going to have a breathalyzer. The police will have a breathalyzer, and they're blowing 0.1 or less than 0.3. Let's say 0.1, 0.15. Yeah, they need to sober up, but let's get them somewhere where they've got a staff where they can keep an eye on them for 6 hours, get them plenty of fluids in there, monitor their vital signs, assuming they want to. And they go there versus going to emergency room. Because emergency rooms, you want real emergencies, right? You want patients with trauma. You want patients that need to be seen acutely. So sobering centers are kind of low-tech ways where people can voluntarily go and commit to staying put for 6 to 8 hours to get the alcohol out of their system. And more cities are having sobering centers. We've had one now in St. Louis for about 2 years, where police and EMS, if they've got somebody, they can go to a sobering center, and somebody at the sobering center can help with back end case management. Do you have a place to live? Are you homeless? Do you need a medical provider, a mental health provider, et cetera? So again, it's a way to shift high resource services to the people who need them more. And rather than having folks end up in jail and prison, if they're safely can go to a sobering center, that's a way to do it. Intercept 1 in orange here, that's where you have the crisis intervention teams. Again, this is diverting people away from jails and minimizing people's contact with criminal justice systems. get folks away from places where they'll probably get substandard care, but also end up in prison or end up in jail where they don't need to be there. Intercept 2, that's where initial people will show up, and they may show up uh, waiting to go to appearance with a judge. Think of people getting stuck in jail over the weekend, in a detention center over the weekend. What you want to do there is identify folks who are there at risk for something bad happening when they're being left alone. Think of people being left without their insulin, without their prescription medication, people who are intoxicated that are at high risk for detox. And what you want, one of the things that we can all advocate there for is making sure we have adequate staffing for our public defenders and our prosecuting attorney's office. Missouri is not a poor state, we're a cheap state, I like to say, which means we chronically underfund our public defenders and prosecuting attorneys. What does that mean? The cogs of law grind slowly. So when you've got understaffed departments like this, people end up sitting in jail and detention for far too long. And that's the least healthy place to sit. If you go off to prison, if you get convicted of something, you've got more room, you've got outside spaces, you've got more flexibility, more autonomy. You're stuck in jail, you're locked down a lot. So in St. Louis and in Missouri, we need to do a better job of staffing public defenders and prosecutors so they can do better work, including staffing diversion courts and treatment courts to keep people out of the system. Now, the next one, if we skip ahead to reentry, what do we do with people coming out of jails and prisons? Pre-arranging appointments as soon as possible. If you know the people behind bars who have substance use disorders or mental health problems, if you've got staff who can make appointments for them so that they're doing their waiting while they're sitting in jail and prison, that means they're less likely to get released without medications on board. In Maine, people are eligible for a 30-day supply of meds and 2 refills. That's super cool. In Missouri, it's a 30-day supply. And in Maine, I know people get sent out with naloxone so that they have it on them in case they're tempted to use opioids again. It'll hopefully keep them alive until first responders show up. And it doesn't have to be high cost folks doing these arrangements. It can be certified peer specialists. These are people who are in recovery, who have additional training to help people who need help to make connections to treatment providers, to their probation, parole office, etc. So, and I mention all these things, not that you all will be jumping in to do all this work, but too often today, I think people think this area is hopeless. It's too big of a problem. There's not enough opportunities. And you guys are learning there are lots of opportunities to make things better. And you don't have to be a physician or a lawyer to do it. You can be a community agency stepping into some of these places. So now community corrections, the last piece, this is where people on probation and parole partner with treatment agencies. We partner with probation and parole in the city and in the county in St. Louis at ARCA, which is my treatment site. We help them figure out, how do you get people to treatment sites? Do they need a bus a voucher, a transportation voucher? How do you get them to treatment? How do you work out? We're working out a system, I think, with our city jail, where if there are people who are going to be released to the community, they are figuring out how at the city jail to get a conveyance van so they can come to ARCA with an officer get started in treatment, and then go back to the jail under all security all the way through so that they get treatment on board before they get released in a week or two. So stuff like that. There are ways to do this work. And that's the ripples in the pond again. So last thing that we'll finish up with, and then we'll have some time for questions. Identify one action to advocate for reform healthcare services for people during incarceration and reentry. And one of my favorites, and I have a couple of her sayings on my inner arm here. Maya Angelou, do your best until you know better, and then when you know better, do better. And I add, now is our time to do better.